The third assumption that we looked at was exactly that question about more after-hours general practice clinics will reduce demand on emergency departments. In looking at this, one of the solutions that the literature often reports is that if we set up co-located GP clinics, or if we set up a diversion clinic located close by to an ED, that will reduce demand. However, the literature, with a few exceptions, shows that these clinics have limited impact on reducing demand to ED. To test this assumption and whether demand could be reduced by diverting patients to after-hour GP clinics, we investigated the role of proximity to ED, or the role that convenience plays in health-seeking behaviour. We found that proximity is a strong influencer in triage 4-5 presentations to ED by our residents. We mapped how many SLAs our residents travel through in order to access the emergency department. And what we found was that the further the resident lived from the emergency department, the less likely they were to present with a triage 4-5 condition than residents that lived closer to emergency. So this first map shows you all triage 4-5 presentations by our residents to all EDs on the left, and presentations to the study EDs on the right. With the darker the colour, the higher percentage of triage 4-5 presentations for that postcode. The few exceptions that you can see there. The percentage of triage 4-5 presentations per postcode is higher when presenting to the study hospitals or their closest ED. And the exceptions, as I mentioned, actually mean that those postcodes, especially from around the inner northwest Medicare Local catchment, and some of those on the side of Hume, still actually travel to their closest ED, but that ED is not inside our region. So they'll travel to Sunshine or to the Western hospitals because the ring road is there and nice and convenient for them. What we can see when we look at, this is actually after hours, when we look at the after hour presentations by our residents, we see those similar patterns. But what we can see here is that proximity to the emergency department plays a greater role after hours. The map also highlights the earlier findings relating to socioeconomic status. So the darker green areas on the left map that you can see are the more advantaged areas of the Northern Melbourne Medicare Local, so the LGAs of Banyule and Nillumbik, and some of the other areas that you can see in the inner northwest, where their percentage goes up, are suburbs like, or SLAs like Essendon and the higher advantaged areas. While we know that if a triage 4-5 resident is transferred to emergency via ambulance, they are unlikely to be a potential primary care type patient. Yet 17.3% of all our triage 4-5 presentations by our residents were transferred to ED by ambulance. In developing this project, we had heard lots of anecdotal evidence regarding ambulance transfers, especially being linked to the type of residence the patient lived in. The table here shows that even though it's 17.3% of all triage 4-5, it's 12% of our residents are being transferred to ambulance in hours and only 10% after hours in terms of numbers. Those that live alone have much higher transfer rates, but again the number is small. And here we see that those that live in residential aged care facilities, 91% of our residents that presented with a triage 4-5 were transferred via ambulance, and 15% of those that were with a police escort. When we did the multivariate analysis here, we also found that for triage 4-5 ambulance transfers, even though those percentages are smaller, they were more likely to occur after hours, even when controlling for age. So we controlled for that high number of transfers from residential aged care facilities. The multivariate analysis was significant. And so the recommendations around that is that what we found was that fundings or payments related to increasing after-hours provision of general practice services should be prioritised to areas where there are limited general practice availability and where there is no emergency department in that SLA. The analysis that we undertook found that the more general practice sites per SLA, the more likely our residents were to present to ED. We also recommended that Medicare Local support general practitioners to develop business and service models that promote improved all-hours access to medical care within residential aged care facilities. That Medicare Locals provide more training opportunities to general practitioners in key gap areas such as paediatric primary care, dental health and refugee health. And that we should quantify the impact frequent attendees and local emergency departments have on the acute and primary care systems in terms of cost, the use of resources and our best practice.
Gareth, do you want to comment?
Well, I found this a bit bizarre. Yeah, I find this a bit bizarre.
So you're not seeing a lot of patients from 2 hours?
No. I mean, to be honest, my ED physicians don't believe 4 and 5s are an issue, as you say. They don't think that's a big issue. But obviously they are more expensive for the system to deal with. If they were primary care, they'd be, more cost effectively dealt with in a general practice thing. But the idea that the more general practice sites there are, the more likely they go to present to emergency is just, to me, just strange.
Is that a proxy for socioeconomic status? There are more general practitioners in richer areas?
No, there's less general practices in the richer areas in terms of in our catchments that are open after hours.
No, I'm talking about in total, because we're not necessarily talking about after hours here.
It's less, sorry.
There are more general practitioners in the eastern suburbs than, say, the northern suburbs, but they're not. Yeah. So just wondering whether that's a proxy for socioeconomic. Did you do a multivariate analysis on this?
Yes.
Yeah, so it's an independent factor.
The problem is
Just get you a microphone. I'll just pinch Gareth. Go on.
thank you. Yeah, and this is a surprising result, and this was the result after the multivariate analysis was performed. So it's controlling for all the variables and confounders that were in our study, but there are some that aren't in our study. I think, as we were talking about qualitative data before, I think a lot of the confounders that are in here are probably things like lifestyle, and the density of general practices is related to the to the city. Melbourne is a key one. And I think it's I'm just speculating as anyone else is about
What are you going to do on your practice?
One theory would be that the accessibility and convenience drives demand, and so basically it's saturating, the service and the demand is being met in those inner areas, and in the rural or distant areas they're either delaying care or not having the care because it's not convenient or it's not accessible. One question I would ask of the statisticians is those areas where they're closer to ED and they have a higher referral to from a higher attendance at GPs as well. Did you assess whether the attendances at ED were referred by GPs, or was that not data you could collect?
We did. We found that only 6% of our triage 4-5 presentations were referred to ED by a GP,
6%.
or another 6, or by another specialist.
But that would be written referral.
Yes.
Because I think quite often what we come across in ED is the patient say, oh, I phoned the GP surgery or I phoned the GP and they said to come to ED, so that wouldn't be captured.
Well, it comes down to how they enter the data.
Well, I find it counterintuitive. I mean, certainly in Cambridge, we felt that if there was an ambulatory urgent care type of centre operating till 9 o'clock at night, we felt that that would reduce the workload. Well, we studied it. Yeah, we studied it, and there was such a centre, and we were putting diagnostics in there to do radiology and so on out of hours. Urgent care.
Yes.
I just asked a question about Medicare Local supporting general practice to develop models for resident care and whether there's been a consideration of different workforce models, looking at nurse practitioner models.
Excellent question. And before we should answer that question, what was the burden of activity related to residents or residential care facilities coming into ED?
So in terms of numbers for triage 4-5, it was about 1,800.
So small numbers overall. But fair to say the people you drag coming in the door.
They're a big burden to the system. They're small numbers, but by and large get admitted and have extended periods of hospitalisation or extended periods in the ED to be turned around with community supports. And so they're complex and they take considerable resources.
And look at the advanced care plans in place. So you know what to do with them.
I think that's a changing piece. I think we are doing a lot of work with Medicare. We are. It's getting better.
But everywhere you go, people say residential care is a big problem. And that strikes me as a failure of general practice.
That's a strong.
It's an issue for general practice. I think it's certainly an issue.
Well, GPs aren't doing the job in terms of providing the care that nursing homes need. There's only a limited number of hospitals and nursing home facilities. Then we're primary health care failing nursing homes.
And one of the solutions to that gap in service that the Austin has delivered, and some hospitals do it differently, is to have an emergency physician drive out to a residential aged care facility to deliver acute episodes of care. It's probably a model which is sustainable, and it's probably the wrong solution to the problem. I think it's about accessibility and maybe the funding.
So the question is a point and well-made one. Do you alternate models of care for residential facilities?
Well, I think that the issue of funding incentives, I think, it was interesting just before the GFC in England that they actually put together both for residential care and for community care payments or incentive payments for virtual teams across GPs, community health services, home nursing and all the rest of it. So not only would you get your usual funding from your normal funding source in terms of your staffing input and other costs, but there would be an incentive payment on the table for that virtual team to provide alternative care, either in the home or in residential care. Now, unfortunately with the GFC, that they stopped that. They weren't able to continue that and look at its impact. But I think there's a huge need for those incentives.
Doctor level or nurse practitioner level?
Whatever was appropriate. Whatever was appropriate, often nurse led.
Yes, I've certainly got a few people mildly irritated.
I was just interested to know what was the evidence that you used to say that Medicare Locals need to provide more training opportunities around refugees, and was there an assumption that refugees are inappropriately using them?
Can we hold that to the next one? Because in fact we cover that in the next. It's a very good question. We will answer it in the next assumption. It's actually more appropriate in the next. So it's in there, but it's one of those overlap areas. So rather than getting into it now, it really is confronted head on in the next one. Yes.
Terry Ahern, I'm a GP in the Group of Aged Care. I think there needs to be more funding for advanced care planning, and that's not voted enough, and a lot of the nursing homes aren't interested. Bupa don't promote it. They think it's too much medical legal risk. It's hard to work with them to try and get any planning done there. There's no funding for GPs doing phone advice or for after hours. And I think the other thing is using the outwork services which come from hospitals to the nursing homes. And like, for example, Melbourne Inreach comes from 6:30 a.m. to 9 p.m. most days and treats most patients better in the nursing home than in the emergency departments.
Just know that one of the things that came out of the international conference here in Melbourne last week was that we should all be advocating strongly that the aged care facility accrediting agency should have as a compulsory element for accreditation should be that within 1 month of admission to a residential facility, a resident must have an advanced care plan in place. The two-year washing period and training, that it is their job, it's not negotiable, and that should be the process. And so, yes.
You were talking about failure in practice and residential aged care services, but I suppose flipping the coin, I think it is an opportunity for Medicare locals to say, okay, this is an area of need both for the hospital sector, but also in the primary care sector. And certainly Terry is a great advocate in our region and has developed models that work really effectively. So I think it's about identifying and strengthening those models and finding other models where those models don't
And using the primary healthcare organisation.
Absolutely.
Whatever it's going to be called after September 14th. Good.
Thank you.
Yes, I come to you and I'll come to Steve Ducker.
I'd just like to comment on after-hours services to aged care homes, and often it reflects a failure of in-hours care. For example, locals often locals are asked to go to an aged care home after hours to sign up a medication chart, and the aged care homes failed to notify the GP a week in advance that this patient's medication chart is going to expire. The other situation is an older person in an aged care home gets out of the bed in the middle of the night, they have a fall, there's no obvious injury, the nurse has said there's no obvious injury, but they want a doctor to come and see the patient. It's a waste of time.
Steve?
One model is for the general practitioners specialise in care of the aged and look after a particular number of residential aged care facilities. That can't work in Australia because the College of GPs, as I understand it, will not accredit GPs to work in that way.
Gareth, want to comment?
Well, I think that, as you've heard, these patients do present, they get admitted, and they're very complex, and they take a long time to get back to their natural bed. So I've always felt now for some years that there should be a general practitioner responsible on roster for every nursing home, and the payment system just have to be sorted. Whatever the incentives are required to do that, that is the natural thing, because they, even if they've got an advanced care plan, they often seem to creep in because the nurse at 9 o'clock on a Friday night or whatever needs to have some confidence that they've got another opinion to call on.
Christine, do you want to comment? No? Yes.
I manage an aged care facility, I work in an aged facility, I work through a residential outreach program, and I want to support everybody who said if you want to improve out-of-hours care, improve in-hours care first. Registered nurses in aged care allowed themselves to become so de-skilled that we're now looking at changing the workforce over with endorsed enrolled staff. I've seen registered nurses say they failed to call an ambulance. I said, where's your Division 1 skills? At what point did you do any more than what a PCA can do? And I think we need to upskill the registered staff in aged care. We need to support them. I don't know where we go from here, but we are seeing people sent into emergency departments because people don't have the skills to assess people anymore. And I think we need to start with registered nurses in aged care and upskill them first. And we've got some great GPs that come in that do fantastic chronic disease management. But if we can't get a GP in during the day, we go locum, we're risk adverse, and go to ED. So in-hours has to be fixed before out-of-hours.
You've heard that loud and clear, and we'll go on the list. Any other comments? Yes. So I see something you might want to no? What's your comment hearing this discussion, which is kind of significantly moves on a little bit from the recommendations out there? So?
In terms of the aged care facilities, definitely that's part of the issues that you're raising are not new to me in terms of what we've been thinking in terms of our own plans. I haven't heard anybody, I heard a few responses when we talked about the ambulance, the number of ambulance transfers for aged care facility, but I haven't heard any comments from that. I know that Ambulance Victoria doesn't think that that's okay. I haven't heard any other comments from anybody.
But I think what they're saying, if I was to prioritize the room, is that if you actually sort out anticipatory care between 9 and 5 in nursing homes, you'd solve a very significant percentage of the problem, including for the ambulance service. And what other options have you got when somebody's demented and not mobile, other than to call an ambulance? And you don't know where the relatives are.
I think in terms of what Fergus said before as well, though, when we're looking at the number of GP practices per SLA, it is a matter of that critical mass and we'll build them there. But if you look at, my neck of the woods, I live near Northern Hospital, and I know that there are after-hours GP clinic services open, but then the sheer number of presentations to the Northern, again, it's people are driving past open centres. So.
I just want to ask Jane a question. Can you start, when I have this conversation, I'm always thinking of Health Workforces Australia after its axiom, which is every health professional should be working to the maximum of their trained capacity. What are GPs doing during the day when they could be doing this? In other words, what do the studies show in terms of what GPs do during the day, and whether they're actually working with GPs or glorified nurse practitioners, and that you could actually change what they do so they become more like consultant physicians, which is really what they're trained to do, rather than see coughs and colds and cuts and bruises or writing out good scripts.
Norman, I think that there's two things happening in general practice. There's general practices that are very well organised and are already operating in the way that you say. They're dealing with increasingly complex cases. It's very rare. It's like there's two realities to the data, I think. If you're looking from the GP perspective, you've got clinics that are doing a lot of complex cases. They're spending a lot of time trying to do what would be assisted by a good social worker, having access to social worker to deal with complex elderly cases that are really difficult to sort out. They're getting improved systems into their practices, and they're working in the way that you're talking about. So how do we see this happening as well? It's also occurring, and I think what Mary was saying about, do we really understand what the problem is? Because I think on both sides there's assumptions by the GPs that the EDs just want the 4/5s to get money for the hospital, and they've got no interest in losing them because they're somehow easy money. And I don't know what the hospital side think of it.
Over 102% bringing any money.
Well, that's sort of one of the assumptions. And on the other hand, you've got the assumption that people think GPs are sitting there doing tick the box, something that doesn't require any medical training. Neither of those things are true. So I don't think we really understand what the problem is that we're trying to solve. Not enough to answer your question.
So the problem that I think we're trying to solve now is not 4s and 5s.
No.
So I think one of the messages that I'm getting from this is 4s and 5s aren't the problem.
The
problem is how general practice works during the day to look after people with chronic complex illness who block ED.
So one of the things that would be great, and some GPs are really good at doing this and others aren't, is to be able to pick up the phone and speak immediately, and I mean, within 2 minutes and get an answer, from specialist colleagues that could avert someone being sent into the hospital. And if that could be done, at the click of the fingers, that would save a lot of unnecessary trips. And I find if, you know, you can speed dial a consultant that you trust, and they'll answer you, and you will avert people going in. Absolutely, and I don't know what the other GPs think, but...
So it's not about a plan to take health consultation, and this is a good old-fashioned telephone being through to a senior registrar, for example.
Yep, and then just being able to get that call taken seriously, answered. I mean, people try, you know, email, all sorts of things. It's around the world. There's all kinds of versions of this happening. But it's got to be just in time.
So it's what used to go through in the old days. Why can't you organise this, Gareth?
There's a cost to it, obviously, because to have anybody answer within 2 minutes, there has to be a bit of spare in the system. But I think that is that and the acute assessment sort of unit, where a patient can be seen very quickly because they're known, because they have chronic complex conditions. You know, separating that from the pure acute procedure.
Part of the registrar's work, you know, second-year registrar's work, that they take the call from GPs and the switchboard knows that. So you've got an ophthalmology question, you go through the ophthalmology registrar, and you just need an identifiable GP and get put through.
Because I think they're quite busy. You know, it goes to the same of systems are pretty busy these days.
And we can't even, within the system, access some of those specialists in a timely fashion either.
So why can't it be one person on a state basis who spends, that you actually have a registrar on a rotation who actually has time allocated, and that anyone in the state can phone this person? Why does it have to be somebody at Royal Melbourne? Why can't you have specialty triage on a statewide basis? Sandy, why can't you do that? You do what I said you do.
I was just sneaking up to Jane. Well, why don't we just, instead of sending them to the hospital and letting them wait there for 3 hours to get the answer, why don't they wait in the GP's office for 3 hours while the GP gets the answer on the telephone?
You're just trying to achieve your unique targets. Yes. And then I'll come to somebody's back waiting for a while.
Can I just talk on behalf of a patient coming to a GP? I have an excellent... Yeah.
I'm really interested.
I'm not a doctor, so that's why I come as a patient. But I have an excellent GP that I have absolute full confidence in, and she's brilliant. And because she's brilliant, more and more people are wanting to go to her. So I have to organise. Well, and I organise with my family of 3 children that we all make sure that we have a booking already in the system once a week. One of us have it because otherwise we cannot get in to see her when we need to.
So you're a landing slot.
And never has one of the family not needed that slot because it is so important that we get to see her. Otherwise, they've got young children, they head off to the ED.
Thanks for that comment. It's racing comment, but...
Norman, can I answer the question you asked earlier?
Sorry, Stephen.
About what proportion of GP visits and so on. We're doing some work on this at Grattan. 20% of GP visits across Australia are managing one condition, maximum of 2 scripts, no other referral, no investigations, no diagnosis, diagnostic tests and so on. So if you use that as a definition of less complex, 20% of GP visits across Australia are of that less complex kind. My favourite little factoid is that there were 45,000 visits across Australia last year that earwax weren't performed.
My comment probably relates to a couple of comments previously. I think people seem to greatly underestimate the value that the patient has on the general practitioner, as was just mentioned by later here, perhaps she's taken it a bit far having a weekly consultation, but it's thinking holistically, and people who've grown up with their GP, they trust their GP, and they want to see their GP to look after all of them. And they don't want to be broken up into bits and pieces. That was the role of the GP in the first place. They could look after all your needs and have the skill to send you off to others who better look after certain aspects. And I think really we need to remember that when we're working out what we're going to do with people in the future.
But my question to you is, can we afford that anymore?
Well, that's a question we have to ask ourselves as a society, but somehow people are going to have to be told that they can't get what they used to get and were told they could get.
You go past a lot of general practices now, they call themselves family practices. What's wrong with the concept of a family practice of what the Americans are starting to call your medical home, which is not just your doctor, you know the people there, you know the nurses, hopefully you've got allied health people there too, you know the receptionists, and that's your home, it's where your family goes.
We've already got that. Our clinic is already that, and I'm sure there's many other clinics here that are that as well.
Or the bit of marketing.
For support to carry it out.
Yeah.
Thank you.
No, it's absolutely a fair point. Yes, Mary and then Charles.
So I just want to make a point, going back to the concept of picking up the phone, there's actually a model, GP liaison at Barnum Health have set up a GP help desk. And the help desk is only open for, I think it's 2 hours each day, on a weekday. It's set hours, it's manned by the GP liaison, so they have a good overview of everything to do with the hospital. And so the GP's phone in there and then gets put in touch with, or they will take on the problem and get back to them.
But that doesn't give you an answer of what you do about the unilateral red eye.
It will get you the answer potentially about the best access to get that treated. Is that something that we can treat in this hospital, and if so, are we the best
But
place?
a good GP wants to know, a single red eye, what do I do? What do I treat it with? I don't want to, they don't want to come to the hospital. Here's the treatment, off you go. And if this evolves, then you need to send
But I think in reality, they're not necessarily the cases that are the biggest burden on the emergency department or on the aged care home. So if you consider the aged care people that are coming in, they're waiting for their colonoscopy. They're still on the waiting list for their gastroscopy. It's quite horrifying when you actually look at the treadmill of referrals that come into outpatients. But if you've got a centralised person that says, okay, I'm going to see where you're up to, you're worried about, this is like PR bleeding, for example. They present to ED.
So
do they need to present to ED?
So isn't that a role for Medicare Local, which is about care coordination, managing the system, health system literacy?
Yeah. Yeah, I mean, it would be great to improve that communication, because I think both sides, both general practice and hospitals, are running on a treadmill and they cannot get off it. And both sides are at the same situation. Everyone is full to capacity, so we can't shift from one to the other. We've got to work out a better way of accessing what we need.
I was picking up on Gareth's point about models of care like AAUs, and I think a good general practitioner knows when a patient needs to be admitted, and the ED is a superfluous step, and they should go straight to an inpatient area.
Or straight to the acute medical or acute surgery unit.
Right. Can I ask, does Victoria has nurses on call? I think other states have doctors on call. Is there a difference between the emergency departments in Victoria compared to other states?
Well, I think we discussed that earlier. The data are equivocal, but essentially child and those services
I was just wondering whether the confidence is that they're worried that she's just a nurse and that they're a bit hesitant to get medical advice from the nurse and get to
do we have data on that?
The GP helpline data, the GP helpline hasn't been, I suppose, running for long enough to get those answers. So there are initiatives in place through the National Health Direct, through the Commonwealth, to actually link those services. Nurse on call here, Victoria is the anomaly, and actually get more of that data out so that we do understand that issue more.
The problem is, as the brochure says, GP on call, and then one of my patients pointed out, on the back it says they're not available in Victoria, it's only nurses.
Even when you call GP help online, you get put through to a nurse first, and only if you triage through do you get to speak to a doctor. Yeah.
As long as rubbish. Sorry, let's go on to number 4.